So what are your initial thoughts about this whole idea of having uncomfortable conversations?
Well, I unfortunately may have been part of instigating this. Last year I debated Zeke Emanuel in the first of these, which then I think drew an audience and people said, well, let's build on that. And that was about the whole issue of whether there should be asylums, places to lock people up. And Dr. Emanuel said there should be, and I said, wait a minute, that's like really retro, that's 200 centuries retro. But there are aspects of what came up today that I think really do need to be emphasized. One is that the pendulum has swung just way too far. When I began in this field in the 60s and the 70s, doctors could do whatever they want. They could talk about to anybody they want. They could lock up anybody they wanted for as long as possible. The pendulum has just swung too far in the other direction. It's just too hard to get somebody into necessary care, life-saving care. It's just too hard to provide information. I have to say, there are 700 psychiatrists that work in my agency. I have to say to them, I personally would rather be sued for providing information than not provide information that results in a tragic clinical outcome. And I think that was part of the point that was made today, that these in the end boil down to individual moments with patients. And I want to make one other point. This is a point I stole from Stephen Colbert in some interview where he was interviewing a woman of color, and he said, I'm colorblind. Can you tell me what color you are? And I think what he was trying to say there is, I'm meeting you as a person. I'm not meeting you as someone who's black or brown or yellow or white. I'm meeting you as a person. And as a clinician, as a doctor, what we know are that the most important effects with a patient are what we achieve, that the alliance that we establish with the patient is based on three things. Understanding, the patient having a feeling that they are understood, that their problem is understood. That doesn't involve color. That they are treated with dignity, which surpasses color, surpasses everything. And finally, that we give them a sense that there is something to be hopeful about. And I think that those are the principles of good medicine, independent of whether it's comfortable or uncomfortable to talk about.
Absolutely. So what role do you think that healthcare plays in combating these disparities between race and poverty that we see?
There are unquestionably huge disparities in terms of access to care, in terms of how long people live, the quality of their lives. This is unquestionable. And one of the points made was that what is the role of health literacy? Steve Clemens tried to bring that up. And there again, it gets down to the individual lesson. It's not about piling people into classrooms and teaching them. It's actually the interventions have to do with sitting down in a doctor-patient relationship and say, I want to say something to you, explain something to you. Tell me what I just said. This sort of give back information is the way that health literacy is conveyed, is taught. Brown bag meetings, bring in a brown bag full of your medicines and we'll go through those. Health literacy is also achieved at the individual patient level. Disparities, from a clinician's point of view, begin at the individual patient level. There are, of course, many social, economic factors that we want to work on: poverty, food, fair education, safe communities, proper education. All of these things are going to make a difference in the health. But from a doctor's perspective, what a doctor can do, what a clinician can do, is in that moment with the patient, and that's what I think the people here can truly understand and can make a difference.
Okay, great. Thank you so much.
Thank you very much.
I really appreciate it.
Thank you very much.